So today we're looking at atrial septal defects. This is where we have a hole in the interatrial septum after birth. So there's a communication between the right atrium and the left atrium here. As you can see, the defect allows oxygenated red blood from the left atrium to move through to the right side. This is a left to right shunt and we call it an acyanotic defect. These account for 10% of all congenital heart disease and generally present later in life as the shunt is at lower pressure than in a ventricular septal defect. The atrial septum forms between week 4 and week 6 of embryonic development, and we'll just draw some rough outlines of the developing heart to see this. The top part is the common atrium, in the middle is the endocardial cushion, and at the bottom is the common ventricle. During week 4, the septum primum starts to grow down towards the endocardial cushion. The space below it is called the ostium primum. By week 5, the septum primum usually reaches the endocardial cushion, and part of it undergoes apoptosis, such that we have a new hole, the ostium secundum. Septum secundum also starts to grow over here. Finally, by week 6, the second septum has formed with a hole in the middle, which we call foramen ovale. This provides an important physiological shunt for blood in the fetal circulation, but usually closes over at birth to form the fossa ovalis. Defects can occur in a number of ways. The first is a septum primum defect. This is where septum primum doesn't grow enough, and is commonly associated with valvular issues. These account for 5% of ASDs, and can occur as atrioventricular septal defects. You can see here there's a gap where the septum primum hasn't fully formed, so blood can get through. Next we have a septum secundum defect. This is where we either have incomplete formation of the septum secundum, so blood can get through here, or it can happen with too much resorption of septum primum or septum secundum, which looks a bit like this. Again, easy for blood to get through. These are the most common types of ASD, accounting for 75%. Thirdly, we have a sinus venous ASD. This is where the pulmonary veins, which usually drain oxygenated blood into the left atrium, join instead to the right atrium or superior vena cava, depicted here. This connection affects the upper portion of the septum and is known as anomalous pulmonary venous return, allowing blood to get through here. It accounts for 5% of defects. Finally, we will mention patent foramen ovale. This is when the foramen ovale stays open after birth. It is still closed over by this valve, it's just not fused, and most of these are asymptomatic, yet there is a risk of what we call paradoxical emboli. Moving on to presentation, ASDs are often asymptomatic until adulthood, but they can present with shortness of breath on exertion, reduced exercise tolerance, recurrent chest infections and wheeze, and arrhythmias from the 4th decade of life onwards. Less than 5% of people with ASDs go on to develop Eisenmenger syndrome from pulmonary hypertension created by the left to right shunt. On investigation, heart sounds will include an ejection systolic murmur at the upper left sternal edge, created by the increased blood flow across the pulmonary valve. There is also fixed splitting of the second heart sound, which we'll talk about in a moment, and a right ventricular heave can often be felt. So what is a fixed split S2? Well, normally we have two heart sounds. S1 over here is caused by the closure of atrioventricular valves, which occurs at the end of ventricular filling. S2 is created by closure of the semilunar valves, and as you can see, the aortic valve always closes slightly before the pulmonary valve at the end of ventricular emptying or systole. This is what happens during expiration, and the difference between A2 and P2 is inaudible. However, during inspiration we have a slightly different picture. S1 is the same, but S2 is split more widely with aortic closure, then pulmonary closure. This is because there is increased right ventricular filling during inspiration, so the pulmonary valve takes longer to close. The difference between the two is created by an increased right ventricular emptying time. So that's the physiological split, which varies with respiration and is entirely normal. In an atrial septal defect, there is always increased right atrial filling due to the shunt from the left atrium. So, there is an increased right ventricular stroke volume throughout respiration, and pulmonary valve closure is always delayed. As we can see, there's splitting during expiration and inspiration. We call this a fixed split, and it should be audible all the time. Other investigations tend to point towards right-sided issues because this is a left-to-right shunt. Chest X-ray can sometimes show cardiomegaly and increased vascular markings due to increased pulmonary blood flow. An ECG in a septum primum defect can show left axis deviation, while a secundum defect is more likely to have right axis deviation, as well as partial right bundle branch block. Echocardiogram can show right heart hypertrophy and dilation, and a subcostal view can actually visualize the ASD. Also, the QP to QS ratio can be used to calculate the size of the shunt on echo, and cardiac catheterization will be the definitive diagnostic tool. The vast majority of ASDs close over spontaneously, but there is a risk of Eisenmenger syndrome, paradoxical emboli if the shunt reverses momentarily, and arrhythmias as a result of right atrial dilatation. So, we treat those who have hemodynamically significant disease. This is when the ASD is large enough to cause right atrial or right ventricular dilatation evidenced by echo, even if the patient is asymptomatic. Ostium secundum defects can undergo transcatheter closure, while all other defects require surgical closure. And for those who are asymptomatic, regular echocardiograms are recommended to monitor for progression.